Everyone, it's Melissa Sweet here, public health journalist reporting for Croaky News from the National Rural Health Conference in Cairns. And we're very lucky here today to have Mick Reid talking with us after he's just delivered a speech at the plenary session of the conference, which generated a lot of interest and discussion. So Mick, can you please introduce yourself to our watchers, our viewers?
Thanks, Melissa. Yes, so Mick Reid, I've been around the health system a long time. Worked in every state and territory of Australia and worked a lot in UN organisations. I had the fortune to be Director General of Health in New South Wales and in Queensland for a number of years, and I was also crossed the Rubicon and was Chief of Staff to Nicola Roxon for some time. But at the moment I work doing consultancy work on boards, mentoring people in different parts of Australia.
And today, what capacity were you speaking to the conference?
Today, one of my roles on the boards is to be Deputy Chair of the Royal Flying Doctor Service, and I've had that role for some years now. So the Royal Flying Doctor Service is the principal sponsor of the conference, and they asked me to talk on a topic around the bang for the buck.
For those who don't know the Royal Flying Doctor Service, could you just paint us a short picture about what it does?
So it's throughout Australia. It's sectionally based, although I'm on the national board. It comes together in a national organisation. It's funded by both state and federal monies. From the federal monies, it's funded to provide evacuations for people in the bush, and does that and has done that for many, many years. And in the states, it mainly does inter-hospital transfers by plane, although progressively now we're doing a lot more by road. And for the last 6 years, I think it's been voted the most trusted non-government organisation in Australia.
Congratulations.
Thank you.
Well, you delivered quite a serve to the audience this morning in one sense. You spoke a lot about the silos, the competition and the lack of collaboration in the rural health sector. Can you explain to us, what... Oh, sorry, so someone said it's hard to hear me. Can you explain to us what you meant by this?
Yes, so I've been around, as I say, been around the health system quite a while, and I do believe there's two characteristics of rural health which really need to be addressed if we are to go forward. There's still considerable gaps, as we know, between rural health and metropolitan health. We know in some aspects this is closing. We know it's really most evident in Aboriginal medical service or Aboriginal people, and the enormous contribution of AMSs have made for that. The 150 of them around the country has been evidence of the change occurring there. But two things occur. One is there's very poor, I still believe, collaboration between multiple agencies, and the study in the Pilbara of the numerous agencies providing service to a relatively small population is evidence of that. And the other thing I think which occurs, and this is just not specific to rural health, but it's much more obvious in rural health, the application of evidence does not occur to the degree it should.
Now, you gave us 3 examples in your session today, 3 quite stark examples of where evidence was available but not widely applied. Would you like to tell us about those?
Yes, so the first one was a 2014 Medical Journal of Australia study that studied 30,000 South Australians who had hospital admissions for myocardial infarction, and it found a 25% difference in the 30-day survival rate for patients who are admitted to country hospitals compared to city hospitals. So that was the study, that was the first starting point. And then they introduced a whole lot of interventions of telehealth with cardiologists based in town, earlier interventions in the country through GP services, earlier transfers for tertiary services using RFDS and other carriers. And today they've found that the gap between country and city has been reduced to 0. The health of the country people with myocardial infarction is exactly the same as the health of the city people. Now the question we would ask is, why is this not translated immediately elsewhere in Australia? But to date it hasn't. It still remains, it's sustained that health gain in South Australia. The telehealth is still proceeding. It's partly taken up elsewhere, but it could have been done so much quicker and with much better health outcomes and much less suffering of people who didn't gain the benefits of this. That's the first one. The second one was to study a very simple one of country people around their sedentary behaviour and introducing a walking program for them. And I found that it really worked in getting country people to get moving and to have much better health as a result of it. Again, not taken up elsewhere. The third one was the study of food vouchers and lower healthy food policy in disadvantaged, particularly Aboriginal communities. The nutritional gains have been demonstrated, but there's still no comprehensive way in which this is rolled out and this evidence is taken to elsewhere in Australia where exactly the same issues occur today. And so one of my real concerns is we don't seem to have a good mechanism of either getting organisations to work together, and we don't have a very good mechanism, I believe, on garnering evidence and evidence that works and applying it more rapidly and more broadly than we do.
So what's the suggestion you put forward today? You dropped a surprise, I guess, for the audience in some ways.
What I did is we looked at the outcomes of the Rural Health Conference 2 years ago, and there were 10 recommendations that came out of the conference. Remember, this is a very important conference for rural health practitioners and others associated with it. It's the biggest one in Australia, and it certainly serves the benefit of bringing together people to collaborate and talk and to understand each other's issues. But I think it's fair to say that of the 10 recommendations that came out of the conference before, they weren't geared in a way that I think was practical, doable, achievable, with sufficient backup, and not done in a way that were understandable to politicians who could latch onto them, and not done in a way that I believe really tries to address some of those fundamental issues which continue to be exacerbated over those 2 years around collaboration of evidence. So the idea was that the Rural Health Alliance, which represents all the bodies who are here today and is a terrific organisation, should think of establishing within its entity a clinical excellence commission of some type for rural Australia, and that will really require the buy-in of all the players who are in the rural health space to work, not just the state and territory health services, not just the primary health networks, not just the Aboriginal medical services and other bodies, but various other groups, multiplicity of peak bodies such as my own. My own is not excluded from this element of silo-based approaches. We're just as bad at how we bring this together and do it in a way that evidence can be disseminated in a much more rapid way, and how you implement the evidence can be done. Our recommendation is to hold it within the Rural Health Alliance rather than in an academic setting, to draw upon the academic evidence from those settings, but to give it a very practical space in which to operate. It's an idea, but it's a thought of how we might start to address those two issues. We don't apply the evidence well, and we collaborate poorly.
So what would be the next step to take this forward?
Well, it's a recommendation to the conference, so I guess it would be debated over the next couple of days at the conference to see where that's an outcome. And then it's really in the hands of the body who's proposed, which is the Rural Health Alliance, as to its response. We've clearly tested it with them prior to making the suggestion, and I suspect it will be positive, but that's an issue for the Alliance, not for me.
Yeah.
And I'm sure you'll introduce Jerry and ask her.
Sure. Is it a significant funding issue? I mean, how would such an initiative be funded?
No, if you look at the evidence of other clinical excellence commissions, I think the New South Wales one is a couple of $1 million a year or thereabouts, and this would be, I would have thought, akin to the same size. It should not, again, promote its own duplication, so it has to draw from where there's specific rural things elsewhere. But I think rather than go in the first instance to government to say, can you fund this, it would be a very good thing for the communities, the organisations who are in rural Australia to say, let us kick this off and let's try and set it up ourselves, because we've heard many, and you know this, Melissa, we've had much evidence presented to us today, and we have a history of things that tend to be seed funded by the government. People will then depend upon that funding continuing, the funding doesn't continuing, and the innovation dies. So I think if we try and move this a little bit to make it an initiative of the communities of interest who work in rural Australia, I suspect that would have far greater benefits and longevity.
Be more sustainable.
Yeah.
I guess just two questions. Where does this fit with organisations that we already have, for example, the Sachs Institute or other such? Is it potentially duplication?
I think it's different from the Sachs. I think the question is relevant for issues such as the Commission on Safety and Quality. Mm-hmm. And I think in creating it, to create it in a complementary way to what the Commission does, or there's 2 or 3 state-based clinical excellence commissions, to complement their activities would be very important, but I think that's achievable. I think there's a clear niche of, in rural Australia, where we have the evidence of differentials in health gain, differentials of socioeconomic characteristics, differentials of the social determinants of health, to warrant the creation of such an entity. And a meeting conference such as this really demonstrates that there is a collective perception of rural health, which is much stronger, I believe, than evidence of New South Wales health or Victoria health. I think the notion of working in a rural health group is a very strong driver of many of the people who are here today.
And the other question, I guess, goes to the naming, because you've referred a few times to clinical excellence commissions. When we've heard this morning that such a large part of the rural health disparities is to do with social determinants, so, you know, to make sure the focus is actually on those wider determinants as well as access to health services.
Yes, I think I'm not wedded to the name. I think it could be anything, because I think even out of that conference, and some of the speakers are on the floor with me, who I'm sure you'll interview, had other complementary parts which could be added to it, which were less clinically focused. But as long as it brings the notion of evidence, I think, to the table, and a rapid translation of evidence, and brings the notion of collaboration, how broad it is really up for discussion.
Fantastic. Are there any last comments you'd like to make?
No, I think it's a great conference, and I hope it will be positively received. It's a thought process, and we do have a long way to go, but I think there's goodwill, and I think we'll get there.
Thank you very much.
Thank you.
Stop now.